Hello and welcome back to the Virtual Care Paradigm brought to you by OnTrack. I'm your host, Jonah Comstock. We've been talking a lot about what the future of virtual care beyond the telehealth video visit looks like. Today, I'm excited to welcome Chris Gibbons, the CEO of the Greystone Group, which is a digital health consultancy that focuses, among other things, on DEI, diversity, equity, and inclusion issues in the space, to talk to me about the health equity implications of virtual care and telehealth, where we are and where we need to be going. Welcome to the show, Chris.
Thanks so much, Jonah. Glad to be with you today.
So tell me a little bit about, from what you've seen in your work at the Greystone Group, what have been some of the hardships that the space has had in terms of equity? What are some communities or groups that are maybe getting left behind?
Jonah, the interesting thing is the easiest way to answer to that is, disparities and equity problems didn't start with technology or telehealth. They were here for a long time before that. And in fact, what we're seeing now as the era of technology emerges is that those same populations and those same people that were generally experiencing those problems before are the same populations and the same people who tend to be seeing the problems now. And so the usual suspects, the low income, people from low income backgrounds, racial and ethnic minority backgrounds, those kinds of things, to name a few, are the types and populations of people who are typically experiencing these in the new generation.
Do you think technology has changed things at all? Has it made it worse for anyone or better for anyone?
Interestingly, technology, we believe, has the potential to make it significantly better, but it also has the potential to make it significantly worse. And it really is up to us, those who are developing and deploying, to get it right. Because if anything, it will make the results occur or be obvious faster, for one. So it's the jury is out just yet. I think there's plenty of examples of where, inequitable outcomes or distribution of these tools and technologies are apparent. But this is really the beginning. So we have an opportunity to fix these things. Some thought that it wouldn't happen in this environment. That's not true. So we have the opportunity, if we embrace it, to close those gaps and make substantial improvement in a way that I think was not possible before technology was being used. But it's also possible that it could go the other way.
So what does that look like? How do we get it right? Is it about broadband access and things like that? Is it about making sure that, we're not too dependent on technologies that other people might not, that not everyone might have?
Like much in healthcare, in public health, it's not one single thing. There is no one silver bullet magic pill or something in traditional healthcare and traditional medicine that fixes everybody. And, I don't know why we keep looking for that in this new technological era. It's not going to be sort of one thing or one solution from our perspective. And because many solutions haven't even been developed yet, I don't know how you could even do that. We tend to think about it in sort of areas and categories, and there are several. One you alluded to is in the infrastructure part of it. So certainly having broadband access, the devices themselves, if you don't have those, you can't participate. So infrastructure is certainly one level to look at here, but there are several others. Another is hardware design, the hardware itself, how is it designed, the user interfaces, the usability of the hardware. All of those things need to be taken into control, because if you don't, you're going to be disadvantaging some populations. So software design on the other is a third area. We've seen examples of how algorithms used often in AI are not having the effect that they intended, and in fact increasing or creating these inequities. So the software design, there's an element there of thinking about it on that level. Then there's what we call sort of using just active systems, systems or solutions where the patient has to actually do something in order to gain a benefit. And that's predominantly what you see now. However, we've known from public health for hundreds of years that active systems are not the best systems at the population level. Passive systems that just work are infinitely more powerful. Some common examples that are so common nobody thinks about them anymore is, iodination of salt. We put iodine in salt and has cured a wealth of problems. Nobody thinks about that anymore. Seat belts in cars, those weren't originally there. So we've got to, in the tech world, start to be thinking more, I believe, about passive systems and building them in an equitable way. And then we can have some true impact. And place-dependent systems, having to go somewhere to get something, well, that poses a problem on people who can't get there, right? And so we still largely have that mentality in healthcare, even with telehealth. Prior to COVID, you had to have an originating site and a service site, that made some problems. But now with COVID opened our eyes, say, well, you don't really have to do it that way. And you don't. And finally, the mental models that people use to design their tools, the way they think about how people make decisions. We have this rugged individualism perspective in the United States, which says, it's me and only me that makes the decisions. And that may be appropriate for some people, but it's well known that there are communities of people and cultures of people that are far more community and family oriented than that. And it actually poses a problem when you build systems that inhibit the ability to involve others in the decision-making process for yourself. And that's more problematic in some populations than others. But these are some of the top ways that we think all need to be considered when trying to design and develop systems and solutions to overcome equity problems in the future.
You've hit on so many interesting, important things there, and I wish I had time to follow up on all of them. But one thing I wanted to follow up on there that I heard was this notion of, can you solve some of these problems before they happen by including people of color, people of low income folks in your design and testing process? And what comes to mind to me is kind of recently it's come out, it's been known by many people that, some of these light-based skin sensors that are detecting some things like blood pressure were just never tested or developed on people with dark skin, and so they don't work on them. And I think that's a good example of how and biased algorithms too.
That's right.
Are you considering these communities from the start? Right.
That's right. Absolutely right. I mean, that's one of the first things. I mean, we wrote some papers on this, and you've got to use a representative set of your typical users. And if you're targeting or you assume that certain populations, you got to test with them. You got to understand. You cannot assume that and the sort of generic, all patients do this is just not true. It's just not right. And if you don't know, you don't know. And therefore, you'll make assumptions that may not be appropriate, and therefore the designs may not be as effective in certain populations as you think they would be.
And the other thing that I heard that I wanted to just call out, this notion of active versus passive. I remember I used to report on public health in New York, and there was a gentleman there who used the term changing defaults, right? Who would talk about, the soda tax as a way to change people's default.
That's right.
Which I think feels like a very related concept. But this idea of, the amount of mental energy that you even have to dedicate to an active change is going to be different based on where you are in society, right?
No, that's absolutely right. And this is a principle that applies, whether you're talking about a tool in the hand of a doctor. Doctors are complaining now, I have too many clicks, I have too many alerts, alert fatigue, I got too much going on. But it's also going to be true on the patient side of the coin. We just have to get away from that. That's only one way of thinking in terms of designing solutions. And there's been a ton written about designing passive systems, not all in the medical literature. And that's one problem. Too many people in the medical sciences and in the healthcare only read, the health sciences and the medical literature, but there's a ton written in computer sciences, human factors and ergonomics that about designing these systems in a way to overcome these problems that many who are designing these solutions from a healthcare perspective are ignorant of and have no no backing in, and therefore they design systems that don't achieve the goals that they'd like them to achieve. But yes, it is well known we can do better, and I think it's exciting when you start thinking about opportunities of AI and machine learning, not in the way that it has been done, but integrating these things in a new way with this sort of passive thinking. We can achieve some astounding things, I think, in the area of equity as well as other areas.
Awesome. Well, thank you so much, Dr. Gibbons. This is great. I've certainly learned a lot, and I hope our viewers have as well. And of course, thank you again to OnTrack for sponsoring this series, The Virtual Care Paradigm.